All right, good morning, everyone. Thanks for being here. My name is Zhenhao Shi, and I'm a research assistant professor at the center. And today I'm going to give you a brief overview of the literature on the functional neuroimaging studies of opioid use disorder. So before I get started, I want to mention that addiction is a very complicated brain disease, and it doesn't mean that there's only like one brain region being accountable for this disease. It's not like there is this one type receptor being affected by this disease. It actually affects a lot of like neurocognitive domains. And if you have a quick look at the RDoC domains and constructs, and you can see that addiction affects pretty much like most of the areas that it mentions, including the processing of positive and negative valences, arousal and social and affective functions, and sensory motor functions. So today I'm going to briefly introduce, first I want to introduce like what is functional neuroimaging, and especially what is fMRI. And then I will discuss four of these neurocognitive domains, including Cue-Reactivity, Inhibitory Control, Socioaffective Processes, and Interregional Connectivity. And I will start by, like for each domain, I will start with a definition, and then I will go into some individual studies for each of these domains. Some of these studies were conducted by myself. And then I will end by introducing a few new methods in the functional neuroimaging research. And feel free to interrupt me anytime if you have any questions. So functional neuroimaging, by definition, it is the use of neuroimaging technology to measure one aspect of the brain function. And there are many different kinds of imaging techniques out there. And according to historians, the earliest kind of neuroimaging technology is probably this thing called human circulation balance, which the idea is like you put a man on a seesaw, and if the man starts to think really hard, then you assume that the brain will require more blood, and the more blood flows to the brain, and it will break the balance. So that was the idea. It was very simple. You can say it's a neuroimaging, but the modern neuroimaging techniques are much more sophisticated. But the idea is basically the same, which is to try to associate mental activity with neuroactivity. So that's the basic idea. And with the modern technologies, we are concerned about mostly three things. The first thing is being non-invasive, which means this technique should not harm the subject. Like you should not need to really open the skull to look at the neuroactivity. So it should cause very little harm, non-invasiveness. The second thing is spatial resolution, because you need this technology to tell you where in the brain is this neuroactivity happening. And the third thing is temporal resolution. It needs to tell you at what time point a certain neuroactivity is taking place. So of all these technologies here, fMRI, fNIRS, MEG, and EEG, I would say the MEG and EEG has the highest temporal resolution. It's like around 1 millisecond. While fMRI, which is what we use the most of the time, it has the highest spatial resolution. It's like around 1 millimeter. And I will say a little bit more about fMRI. So fMRI basically uses the MRI scanner to measure neuroactivity. So we use the scanner to measure the brain, and at the same time, we want to somehow manipulate the mental activity while we are scanning the brain. And we manipulate mental activity using external stimulus, like visual stimulus or auditory stimulus, to manipulate what the subject is thinking during the scanning. And then we use a behavioral response device to try to record their task performance as an output of their brain response. So that is the basic setup of an fMRI environment. And then how do we measure, like how do we associate mental activity with the neuroactivity that's measured by fMRI? So you can think of like two different kinds of mental states, like a baseline mental state and an active mental state. So as your mental state, as your mental state goes from baseline to active, like you can imagine that some of your neurons will go from baseline to active. And this kind of neuronal activity will require oxygen. And what our body does is that it actually supplies more oxygen than what is being needed for that neuron to do that kind of neuronal activity. So, which means that like if there is a mental activity goes on, then there will be a change in the ratio between the oxyhemoglobin and deoxyhemoglobin in the brain region where the neural activity is happening. So what does this mean? Like why is this useful, right? Well, a useful thing is that oxyhemoglobin and deoxyhemoglobin, they have different magnetic properties. Like one is like slightly attracted by the magnetic field, one is slightly rejected by the magnetic field. And if you put them like in a scanner, which provides a magnetic field, if there is a change in the ratio between the two things, it can somehow be detected by the MRI scanner. So that was the basic idea. So as you have like mental activity going on in your brain, certain brain regions has like a change in the ratio between the two hemoglobin, it will be detected by the MRI scanner. So as an example here, let's say like if you have like a visual stimulus going on, let's say if you turn on a light in a scanning room for 2 seconds and then turn the light off, then you can imagine like some neuron in your visual cortex will start to fire almost immediately, like when you turn on the light. So that's the actual neuronal activity, the neural activity in the brain. And then this neural activity will cause changes in the ratio between oxyhemoglobin and deoxyhemoglobin, which get detected by the MRI scanner and turns it into an fMRI signal, which is a hemodynamic signal. It's about the blood flow change, right? And the fMRI signal will actually look like this. It's much, much slower, it's smooth. And you can see the peak of this fMRI signal is actually after this whole thing has already ended. So there is a delay, but there is a nice correspondence between neuronal activity and fMRI signal here. And usually the fMRI is kind of like a noisy measure. So usually you will not have like a smooth curve. You will have like kind of a zigzag curve looking like this. And our job is to get this kind of zigzag fMRI like noisy signal and try to infer what was going on in the brain. So like if whenever I see this, I can start to imagine, there must be some neuronal activity going on, kind of maybe like this, which means that there must be some mental activity going on like this. So like when you see this fMRI signal, you are trying to infer back to what was going on at the neuronal level and try to associate it with the mental activity. So that's basically how to interpret these fMRI findings. And now in terms of spatial resolution, the fMRI scanner measures the brain by dividing the brain into like tiny little pixels. And because it's 3D, we call them voxels. And so the smallest element, which is the voxel, is about 2 by 2 by 2 cubic millimeter. That's about the spatial resolution of fMRI. And the temporal resolution now is about like around 1 second. It's like you measure the fMRI signal every 1 second, so that for every single voxel, you basically have a time course with the temporal resolution of 1 second. So if you scan the brain for 5 minutes, you will have like a time course for each individual voxel. And then how do we study those time series? How do we study the time course? So let's imagine, like, let's say if you design an fMRI study like this, like you want to study how the brain like encodes the visual information versus the auditory information. What you can do is that while the person is lying in a scanner, you present some sound and then rest, and some light, then rest, and then sound and rest, and light and rest. So you present these things to this subject, and the subject's brain will start to encode all this information you put in there. So if you put out a voxel in the visual cortex, and you will see that this voxel probably has a time course like this, because the visual cortex only responds to visual signal. It does nothing to the auditory signal. So this is what you will see if you do this kind of experiment and you take out the time course of one voxel in the occipital cortex. Of course, you can take out the voxel from another cortex in the brain. Let's say you take out one voxel from the posterior insula, which is a multisensory brain region. It responds to all kinds of sensory input, both light and sound. Then you will see a time course looking like this. So by looking at the two different kinds of time course, it can tell you like what this brain region is doing. Like this brain region is responding only to light. It's probably a visual cortex. Without looking at the brain, you can already tell it's probably visual cortex. While looking at this time course, you can probably tell, well, this is probably a multisensory brain region in the brain, which is probably in the posterior insula. And then what we do is that we do the same thing for every single voxel in the brain, and we then map. We try to like use a color map to indicate like what are the brain regions that has the highest response to visual stimulus only compared to baseline. And of course, you will find a lot of voxels in the visual cortex at the back of the brain. You can also ask like what are the brain region that responds to both light and sound. And if you like try to like isolate like all these like important voxels, you'll see that all these voxels are in the posterior insular cortex. So that's how you use this kind of color to indicate the level of activation to different kinds of stimulus. And in the literature, when you look at the fMRI papers, like sometimes you will see the activation map looking like this. Like you can, this brain is 3D, you can cut the brain into like X slices, like sagittal X slices, or coronal Y slices, or axial or Z slices along the 3 different dimensions. So this is one way to visualize the results. Some people do it in a more fancy way. They visualize the results by plotting the brain on this like a surface, like a cortical surface. Like you can have like different ways of viewing this surface. You can like pump it into a balloon, or you can pop it. So there are many ways to visualize the results, but I want to mention that all these kind of visualizations, they are identical. Like it doesn't matter how you view them. It's just a way of like showing the results. What actually matters is like what are the actual anatomical regions and what are the level of activation. It doesn't really matter how you show these results. So they are basically identical. So that's pretty much about functional neuroimaging and fMRI. Any questions? Okay, I will then move on to talk about Cue-Reactivity. The Cue-Reactivity is probably one of the most well-studied phenomenon in fMRI literature for addiction. And by definition, Cue-Reactivity is a type of learned response in people with an addiction to presentations of drug-related stimulus. And this response can be either subjective or physiological. So the idea is that an originally neutral stimulus can become a conditional response to drug after that stimulus has been repeatedly associated with drug use. And then once it's this kind of association is established, exposure to this kind of stimulus can trigger conditional responses like craving or withdrawal, which in turn can trigger drug use or relapse. And there have been multiple meta-analyses already about the brain regions that respond to this kind of drug cues. And one study, like one meta-analysis looked at nicotine and alcohol and cocaine. They found that these cues, they activated the bilateral nucleus accumbens. And another meta-analysis, they included a few more drugs, and they also compared against the neutral stimulus. And they found that the drug cues activate like a large network of regions, including the ventral stratum accumbens, the medial prefrontal cortex, the amygdala, which is very similar to the brain response to natural rewards. So several factors can affect Cue-Reactivity, including withdrawal and abstinence. Like in this study, they only found Cue-Reactivity in the ventral stratum and the medial prefrontal cortex after a short period of abstinence, but not after a long period of abstinence. And also our own study found that there's a correlation between withdrawal severity and Cue-Reactivity. It's like if you have more severe withdrawal symptoms, or if you have like a more severe drug use in the past, you tend to have higher Cue-Reactivity in the ventral stratum and the amygdala. And as I mentioned, the exposure to the drug cues can increase your craving for the drug. And there is evidence that the brain response to the drug cues is actually positively correlated with the cue-induced craving in the ventral stratum and the dorsal stratum. But however, like if you ask the patients how much they like these cues, you will see a different picture. It's like they like the sexual pictures. They like the naturally rewarding pictures more compared to the drug-related pictures, followed by the naturally aversive pictures. But when you look at their brain response, they actually have the highest brain response to drug-related cues compared to the naturally rewarding and aversive cues. So which means that like a higher cue reactivity does not necessarily mean like they really like this kind of stimulus.
Zhenhao.
Yes.
May I ask you a question about the previous slide?
Yes.
So the model down at the lower right suggests there could be a mediation
Yes.
by withdrawal severity. Did you model that in your analysis as a mediation?
Yes, it was a mediator analysis.
Oh, interesting. Okay.
Yeah.
So just to be clear for the students, a mediator analysis speaks to causal links. And so drug use severity is causally linked to withdrawal severity, which is causally linked to Cue-Reactivity. And so that's an indirect effect. In other words, it's mediated by withdrawal severity. So the more drug use there is, the more likely someone is to have withdrawal, and the more likely they are to have Cue-Reactivity. Is that a fair summary, Zhenhao?
Yes, that's accurate.
And the paper that Rachel published yesterday is a mediation paper for alcohol use disorder and drinking, but it's a genetic mediation paper. And so maybe we can read that as well. Mediation can be a very powerful way of modeling causal effects, not just association or correlation, but actual causal modeling. Sorry to interrupt.
Yeah, I strongly urge everyone to fully understand what is mediation and what is moderation. I think those are important concepts for this.
So do you want to mention what moderation is now that we've discussed mediation?
Yeah, sure. Moderation is kind of like mediation, but it's totally different. Moderation is like if you have two things associated with each other, but the level of association or the direction of the association depends on a third variable. So it's like one thing is positively associated with another thing in one group, but negatively associated with the other thing in the second group. Then you can say that group is basically a moderator. It's moderating the direction or the strength of the association between X and Y, which is different from mediation, basically. Okay, I'll move on. So Cue-Reactivity has also been associated with treatment outcomes. For example, like ventrostratal and cerebellum Cue-Reactivity has been shown to predict a relapse in methadone treatment, maintenance treatment, and also the medial prefrontal Cue-Reactivity has been shown to predict adherence to naltrexone treatment in OUD patients. And also there is Cue-Reactivity can also be modulated by treatment itself. For example, in methadone treatment, there is a reduction in amygdala Cue-Reactivity from before the methadone dose to after the methadone dose. And also in injectable naltrexone, there is also a reduction in Cue-Reactivity from pre-treatment to on-treatment. And in one of our own studies, we tested the specificity of the naltrexone effect on Cue-Reactivity, and we found that naltrexone only reduces brain response to drug cues, but not to the natural cues, suggesting that the effect is probably specific to drug stimulus. And also in the same study for a small group of patients, they also received like 3 total injections of naltrexone. So in addition to the first 2 time points, we also measure their craving and Cue-Reactivity at like about 4 weeks after the last injection. So which is kind of like after the treatment has ended. So we found that the craving continued to decrease after the treatment ended, but the Cue-Reactivity went up even more so than the baseline. So basically suggesting that the 3 months of naltrexone 3 months of treatment with naltrexone is probably not sufficient to really bring the brain response to baseline. And then we also looked at the role of depression, and we found that patients with a higher depression score tend to have less reduction in Cue-Reactivity from pre-naltrexone to after naltrexone. So there was a negative correlation for both cue-induced craving and cue-induced brain response. So to summarize, in OUD patients, drug cues activate the brain reward system, and this kind of brain response is modulated by abstinence and withdrawal symptoms. And Cue-Reactivity is also associated with craving but not liking of the cues. So and this Cue-Reactivity can also be predictive for treatment outcomes. And lastly, the treatment appears to reduce Cue-Reactivity, although the reduction may depend on adherence and other psychiatric comorbidities. And now I'm going to move on to the second domain, which is inhibitory control. And by definition, inhibitory control is one's cognitive ability to inhibit their impulsive or habitual behaviors in order to select a more appropriate behavior that's consistent with their long-term goals. And inhibitory control is usually studied by this go-no-go paradigm, where the subjects have to respond to the frequently presented go stimulus while inhibiting this kind of habitual or impulsive behavior response to occasionally presented no-go stimulus. And some people use those kind of neutral stimulus for this go-no-go paradigm, which is just a regular go-no-go paradigm. And some people tend to use emotional stimulus, like, for example, responding to the frequently presented appetitive stimulus, but trying to inhibit the response to the infrequently presented aversive stimulus. And this is one example of this affective go-no-go paradigm. And a meta-analysis of the healthy control population showed that inhibitory control requires a large network of the brain, including the prefrontal and parietal cortices, the anterior insular cortex, and the ventral and dorsal striatum. So it requires a lot of brain regions to work to really carry out this kind of inhibitory control. And a comparison between patients with addiction and healthy controls mostly show a reduced brain response during inhibition, mostly in the prefrontal cortex. So two studies have compared heroin users versus healthy controls, and they both found like a reduced prefrontal neuroactivity during inhibition. And there was also an EEG study. So EEG study, so they basically measured an like a component called N2, which is an electrophysiological response to no-go versus go stimulus. And this kind of component happens around like 200 milliseconds, like around the medial prefrontal cortex region. So, and this kind of N2 component, so this little waveform here is considered as like a biomarker of inhibition. And you can see that these healthy controls, they have like a higher electrophysiological response during this time compared to the heroin users. So which is basically consistent with the fMRI findings that these patients probably have some sort of deficit in the prefrontal cortex in response to inhibition. In terms of treatment response, so one study looked at a heroin maintenance treatment, which is a kind of treatment that I know very little about, but they were looking at heroin maintenance, and they found that an acute dose of heroin reduces prefrontal activity during inhibitory control. And also there was another EEG study looking at comparing between healthy control and methadone treatment and no treatment. And they found that the healthy controls and the methadone treated patients were kind of similar. Like they all have this pretty healthy like N2 response during inhibition. But for patients who were not receiving treatment, the response was much smaller. And there were also studies on non-pharmacological interventions. For example, this study looked at aerobic exercise, and they found that this kind of exercise was able to increase the N2 response to no-go versus go stimulus at the prefrontal region. And there was another study looking using TACS, which is a non-invasive neuromodulation technique. So like if you stimulate this brain region, this lateral dorsolateral prefrontal cortex, they found that stimulating this region can improve their inhibitory control behavioral performance on this inhibitory control task. So which means that this is probably an important region in this population in terms of inhibitory control. And then studies have also used affective go-no-go task to measure inhibitory control. So this is one of our older studies, and we found that the behavioral performance during this go-no-go task, as well as the ventral striatal response during this task, can predict their treatment response in terms of their adherence to a 3-month naltrexone treatment. And we also did a multivariate analysis, and we found that the overall drug use severity score was associated with a large-scale pattern of deactivation during emotional inhibitory control, which suggests that the impact of addiction on this kind of inhibitory function is probably not just mediated by one region, but by like multiple brain regions across the entire brain. So to summarize, studies found that OUD patients, they tend to show reduced prefrontal and anterior cingulate response during inhibitory control, and medications seem to somehow modulate the underlying neural responses, and also exercise and neuromodulation treatments seem to improve inhibitory control, and also the brain measures of emotional inhibitory control might be linked to addiction severity and treatment outcomes.
Zhenhao, I have another question.
Yes.
I'm trying to model asking questions, by the way. The effects of medications seem to be irrespective of the mechanism. So in other words, agonist treatment or antagonist treatment both seem to have effects on inhibitory control, kind of remediating inhibitory control. Are these placebo-controlled studies?
Let me see.
Yes, saline.
Yeah, I think for this one, for example, this heroin maintenance treatment, I think they just have one group. I think it's just one group. They don't have control.
I see, but they got saline.
Yes.
As a control. Yeah. So the reason I'm asking is because when I see these kinds of effects by opposite acting drugs, so an opioid agonist like methadone and an opioid antagonist like naltrexone, it makes me wonder how much of the observed effect is an expectancy effect among people who are on a drug that they think will help them.
So first of all, I mean, for inhibitory control, I think it's not something that's easily like affected by expectancy, because it's like it really tests your cognitive ability, I think. So
it tests what? I'm sorry.
It tests your cognitive ability to do this task because it's a difficult task.
Right.
But on the other hand, I think almost all these studies, they have a small sample size and they are not really very well controlled. So I think if it's not expectancy, I think maybe like natural recovery can also be a role. Like I think there are confounds there for sure.
It's interesting, but
and already they are not consistent already. I think some of them are already not very consistent with each other. So it's a messy area, I think. It's not very clear.
Thank you.
Yeah, so I say the appeal to affect the neural correlates. I'm not even clear about the direction. So yeah, it's pretty inconsistent. Okay, next I want to talk about the socioaffective processing, and this is basically a very vague, a very like a large term, like for a lot of phenomenon. And it's basically like, so social neuroscience and affective neuroscience are like two broad like fields of studies. They basically look at like how the brain responds to like emotional and social experiences. And in addiction, it's not uncommon to see social affective impairments. So to start, I want to talk about like how the brain responds to monetary reward. And so monetary reward is kind of like a natural reward, like compared to like drug reward, because like healthy controls, like we will have brain response to monetary reward. But like one study compared heroin users versus healthy controls, they found that they have reduced a reward system response to gaining reward and also to avoiding loss, which means that like they are not as sensitive to this kind of monetary incentive compared to healthy controls. And another study basically replicated the previous finding, but they added another abstinence group. So they found that this abstinence group, when they are not under treatment, they are more like the healthy controls when they are doing reward processing, and they are more like the methadone-treated patients when they are processing monetary loss. And studies have also looked at how the brain responded to like natural reward stimulus. And they found that depressed OUD patients, they tend to have less frontal striatal response to social cues compared to healthy controls, which could be attributed to either depression or OUD. We don't really know. And there were also FNIR studies. So FNIR is basically very similar to fMRI. It's also measuring the oxy and deoxyhemoglobin in the brain, but it's more like local measures of the prefrontal cortex in this study. And they found that there is like when you compare OUD versus healthy controls, there were less prefrontal response to social cues and food cues. And also, if you do the same comparison between OUD with anhedonia versus OUD without anhedonia, they also found there was like a reduced prefrontal cortex to social cues and food cues. And then they did a correlation between the prefrontal response to social cues and a measure of demoralization. And demoralization is basically a sense of existential anxiety, like you're feeling meaningless, you're feeling hopeless, and you're unable to cope with your daily stress. And that's basically demoralization. And they found if you have like a lower prefrontal response to the social cues, then you have a higher subjective feeling of demoralization. Studies have also looked at how the brain responded to facial expressions, which is like a very old paradigm in studying like how the brain encodes emotion. So this study, they were comparing heroin users versus controls, and they found that heroin users, they have less amygdala response to whatever emotional stimulus compared to the neutral facial expressions. And they also found that the occipital cortex, the visual cortex, were less responsive to positive emotions compared to negative emotions in heroin users. But however, another study, I think they did pretty much the same paradigm. It's again this heroin maintained population versus controls, and they found that the OUD patients, they actually have higher amygdala response to the fearful faces compared to healthy controls if it's under epidecedin. However, if you give them an acute dose of heroin, it will reduce this amygdala response to fearful faces. So which is kind of complicated. It's not really consistent with the previous study. And for our own study, like we asked another question. So we were asking like instead of looking at the brain activation alone, we were asking like whether there's a correlation between the brain response and how well they can really differentiate between different emotions. So we were basically correlating brain response with their behavior accuracy in this emotion recognition test. And we found that for methadone patients, there was a negative correlation, which means that this kind of amygdala response is probably kind of like a distraction for them to really do this task. While for buprenorphine patients, there was a positive correlation. We don't really know why, but it looks like different kinds of medication. They probably like have like different effects in terms of emotional processing. People have also looked at like how OUD affects your like caretaking, the neural correlates of caretaking. So in this baby face paradigm, so this is one of our own very small pilot studies. So we measured OUD mothers' brain response to baby faces. So we showed these baby faces to mothers with OUD who just gave birth to their own babies. So we found that their brain response in the ventral striatum and the medial prefrontal cortex was positive correlated with their self-reported connection with their own infant. And then another study looked at, and they manipulated the level of cuteness of these baby pictures. So they were basically looking at the brain response to the very cute babies compared to the less cute babies and compared to the really not really very cute babies. And they were looking at the effect of extended release naltrexone, and they found that before naltrexone, the patients cannot really differentiate between like the different levels of cuteness of these BB faces. But after treatment, and there was a significant reduction in brain response to the less cute baby faces, but less reduction to the most cute baby faces, suggesting that like the naltrexone might play a role in like increasing your sensitivity to cuteness. To summarize, I know this is very messy literature, but that's the reality. So basically, the OUD patients, they seem to show reduced neurosensitivity to non-drug reward that might be associated with socioaffective impairments. And also OUD patients, they appear to have some abnormal amygdala response to emotional phases that might be somehow modulated by treatments. And also treatment seem to modulate the neural correlates of caretaking. Not very conclusive at all. Any
I just had
questions?
a quick question. Yeah, I had a
Yes.
quick question about the mother study. Did that include or exclude patients with postpartum depression? Because that then may affect like the response to the child faces.
Oh, good question. I don't recall. I don't recall. I'm sorry, but it was a very sample. So they all have to like finish the study. So I assume they should be somehow functional to finish all the entire study, which takes a few weeks. Like there's fMRI and there's behavioral follow-ups. So I would assume that even if they do have depression, it shouldn't be that severe. Yeah, because they did somehow manage to finish the study. Yeah, good question.
How large is the sample in the study?
I can count. I think it's 12. 1, 2, 3, 4, 5, 6. So I think
Oh,
this
I
is
see. I see. Okay.
yeah, it's extremely small. Sample size is extremely small. Okay. All right. Next, I'm going to talk about interregional connectivity, which is something that the MRI scanner can measure. Because yeah, so for connectivity, there's like two kinds of connectivity that we talk about. In terms of MRI, there is a structural connectivity and there is also functional connectivity. So for structural connectivity, we are talking about the actual white matter tracts that physically connects like different brain regions. That's the structural connectivity. And for functional connectivity, we are mainly talking about a statistical dependence between the time courses of different brain regions, such as correlation. So that's really a statistical measure. And here I will mainly, because there's a lot of research on connectivity in addiction and also in OUD. So, and here I will just mainly focus on the seed-based functional connectivity regions where people like pre-specify like a seed region and try to examine like whether this region is connected to the other brain regions and whether those connections were different between like say like different cohorts. So two studies have looked at the connectivity for amygdala and the accumbens, and they found that for both regions there appears to be an increased connectivity with the temporal parietal cortex and subcortical regions, and a reduced connectivity with the lateral prefrontal cortex in OUD patients versus healthy controls. And this is a very interesting study because they look at the effect of abstinence on both structural and functional connectivity between the medial orbital frontal cortex and the nucleus accumbens, both of which are part of the brain reward system. And they found that going from short abstinence to long abstinence, there was a significant increase in structural connectivity between the two regions, and for the functional connectivity between the two regions. And they also found that there was a negative correlation with craving for both structural and functional measures, such that a greater increase in this structural and functional connectivity, they were associated with a significant reduction in opioid craving across abstinence. And studies have also tried to associate functional connectivity with treatment outcomes. In the first study, they looked at the nucleus accumbens connectivity, and they found that accumbens connectivity with the frontal parietal cortex can predict relapse in 2 years during methadone treatment. And also in our own preliminary study, we found that connectivity between accumbens and the medial orbitofrontal cortex and a region in the temporal cortex can predict their adherence to injectable naltrexone treatment. And the last study I wanted to mention is that so this is a recent study that looked at the effect of prenatal opioid exposure. So they were actually scanning the babies, like the newborn babies, to see how their brain connectivity looks like. And they grouped the babies based on their mothers. So they compared the babies of mothers who had OUD and received treatment during their pregnancy, compared to the babies of OUD mothers who did not receive treatment during their pregnancy. And they found that the babies of mothers who did not receive treatment, they tend to have abnormal connectivity pattern in the right lateral prefrontal cortex and in the medial orbitofrontal cortex. So they found these two regions, they have particularly like different brain connectivity patterns compared to the other groups of babies. And what they found is that for this medial orbitofrontal cortex, they found like a significantly reduced connectivity in babies whose mothers were not treated. And they also found that the connectivity between the right prefrontal cortex and the occipital cortex, there was a significantly higher connectivity in babies whose mother were not treated compared to the other babies, which is a very complicated finding. I think it's very hard to interpret, but the author tried to interpret these findings, and basically it kind of suggests that the treatment status of the mothers could somehow modulate this brain connectivity of the babies after they were born. So to summarize, the OUD patients, they have reduced amygdala and accumbens connectivity with the lateral prefrontal cortex, and the frontal and striatal connectivity appears to be associated with treatment status and treatment outcomes. And also medication for OUD during pregnancy might have an effect on the baby's brain connectivity.
Can we discuss the clinical relevance of the first bullet, for example? So yeah, that's fine. So if OUD patients have reduced connectivity between amygdala and nucleus accumbens with lateral PFC. So lateral PFC is a frontal region involved in executive function. So executive function is, is basically judgment, to really simplify it. So that part of your brain is what helps you make appropriate judgments about things. And if you are not connected to that, if your brain is not as well connected to that region by regions in the lower in the brain, more caudal in the brain, like the amygdala, which encodes a lot of fear responses, and the nucleus accumbens, which represents a lot of pleasurable experiences. There's this disconnect with executive function, and so people are not with OUD. And correct me if I'm wrong, because I'm jumping way ahead here. People with OUD are not making the connections to inhibit or to execute behaviors that are appropriately related to things like fear responses and pleasurable responses. Is that a fair leap?
Yeah, I think that's the leap that most fMRI researchers would like to make. But it's hard to prove that kind of leap. But one would imagine that if you have a lower connectivity, that means you have poor kind of top-down control of your impulses or your emotional responses. You have a poor self-regulation, or yeah, or like self-monitoring, or like inhibitory control over those impulses.
Right.
So I think that's a natural assumption, although from this kind of research alone, from this structural or functional connectivity studies alone, that kind of conclusion is kind of hard to make, because what they do is to just look at like whether these two regions are really connected,
Right,
but
right, right,
doesn't
right.
really tell you what these connections do.
I just want to put it in some kind of an interpretive background, provide some interpretive background so that the students know what it is this may be useful for. It implicates that kind of a model. It doesn't prove it, but it
Right.
provides a basis for testing it more precisely for its validity.
Yes, I think of the best way to test this hypothesis will be use neuromodulation. Like if you find a particular region in the prefrontal cortex that has reduced connectivity to amygdala or accumbens, you can try to like somehow manipulate the neural activity in that prefrontal cortex using, for example, neuromodulation, or you can do cognitive training to like somehow improve the function of the prefrontal cortex, and to see if that changes like any of these connectivity measures, and in turn changes the
Right.
your performance behaviorally.
Right.
Yeah.
Thank you. Thank you.
Okay, that's all the domains I wanted to talk about, and now I wanted to mention some of the new methods that neuroimagers are starting. They've been using them for a while, but it has been shown to be more useful in terms of clinical research. And one of them is this graph theoretical or network analysis of the brain connectivity, because the idea is that different brain regions, they are supposed to work together rather than working independently. And so there has been an interest in understanding the interactions between different regions in the form of networks. And there are many new matrices that metrics that have been proposed based on graph theory and network theory in order to characterize like how the different brain networks are organized. And these have been applied to both structural and functional connectivity, and have been used to study many psychiatric disorders, including addiction. I'm not going to like introduce like all of these definitions. I think if you're interested, you are welcome to Wikipedia. So these are actually very sophisticated like ways of calculating like the properties of the brain functions. Some of them are not very straightforward in terms of their neurobiological meanings, but some studies have found that these matrices have certain predictive values. And also there are different neuroimaging techniques, like I have mentioned, like they vary in temporal and spatial resolution, and they measure different aspects of the brain function. And even within MRI alone, like there are different functional paradigms and structural indices that could somehow be combined to make like a more complete picture of an underlying mechanism. And also there are like different statistical methods that are available to achieve this kind of multi-model data integration. And so like putting all these measures together can probably give us a more comprehensive understanding of the neural mechanisms of addiction. And lastly, I wanted to mention machine learning, which is a special form of multivariate analysis. Because many times, like let's say when you try to, let's say you want to separate a group of patients from controls, and you have only one variable, and this kind of separation could be difficult if that variable is not like really that powerful in terms of differentiating. But sometimes when you put like different variables together, and this kind of separation can suddenly become really, really easy. And that's what machine learning is trying to do. It's trying to like put together like a large number of variables and try to extract the meaningful information from this large number of variables. And under machine learning, there is two kinds of machine learning, mostly. One is called unsupervised learning, which is basically using like the available variables to try to identify a hidden pattern within the data sets. And this approach can be used to, for example, to categorize patients into biologically or clinically meaningful subtypes. And also there is another kind of machine learning called supervised learning, which is basically try to establish a model using data where the pattern is already known, and then apply this model to a new data set and to try to infer the pattern in a new data set. And this is the common approach when we are trying to use, for example, brain measure to predict like treatment outcomes in the future. That's it. Thank you for your attention.
Great. We have some time for questions.
I had a question like from the reading also, because it discusses how like in the Q things you also discussed how like differences in the baseline neural response to the Q could also cause like differences in how like one responds to the treatment. So like I was wondering if like it would be like an interesting thing to like do an experiment on basically how like the baseline differences in the drug use like could like in a way affect like what treatment someone is given, or like if there's a treatment that's like better depending on like if you have reduced or like not response.
You're talking about the Cue-Reactivity paradigm, like
How can that be like applied in the sense of treatment is my question.
Yeah, I think that's an interesting question. So I think some of the recent studies what they are trying to achieve is to see like whether you can gain some clinical insights at baseline using neuroimaging or using whatever you have to somehow predict like how well this patient will benefit from a certain type of treatment versus another kind of treatment.
Which is a moderator analysis.
Yeah, I think yes. So I think that's what everybody wanted to do, but also I think it's really hard because I think first of all to do this kind of like to achieve the analysis you will first of all you will require a large sample, and then you will basically you will need to have their baseline measures, and you will need to like observe them for a long time to see how they benefit like from one treatment versus the other treatment. So I think theoretically this is doable. If you are measuring the right thing in the brain, let's say if Cue-Reactivity really matters in terms of their treatment benefit, then I think with a large enough sample and with the correct algorithm, you should be able to like establish this kind of model theoretically. But on the other hand, like no one is 100% sure that Cue-Reactivity really tells you anything about their subsequent benefit from a treatment versus another kind of treatment. So I think the theoretical challenge is probably more than the actual technical challenge, because we don't really know like whether Cue-Reactivity is the right kind of neurocognitive construct to be looking at.
Like how could one see if it is the right construct?
Yeah, I guess no one knows. I think what people like trying to do like with machine learning is that like we just measure whatever we have. We just measure whatever we can think of. We measure Cue-Reactivity, we measure impulsive control, we measure connectivity, we measure like brain structure, and we do a lot of like behavioral measurements. And then we have like 1,000 subjects and we throw them into machine learning model and see what comes out. I think this is one approach that's purely data driven. I think that's one approach, but there should be more like smart ways of pre-selecting the relevant variables, I think.
There's a parallel issue with pharmacogenetics, where instead of imaging as predictor measures, you use genetics, and it's the same problem. It's the effort to be precision treatments based on some characteristic of a subgroup of individuals, and it's a real challenge, but it's a very exciting way to approach things.
Yes, and another thing is that like sometimes I talk about this kind of research to people, And also once, like, I think I was submitting a grant, like using this kind of like machine learning, like neuroimaging. And some of the comments were like, okay, you are looking at the brain, but what about things outside of the brain? Like, what about those external factors? And I remember like one of the reviewers were basically saying like you're measuring brain activity, but probably the distance from the clinic and where the patient live is probably a more important predictor of treatment benefit than all the than all the fancy things you measure in the brain. Like all those external factors probably sometimes play like a way larger role in this kind of prediction.